Hi, folks, and welcome to the webinar, New Developments in Ovarian Cancer Surgery. We're just waiting for a couple more folks to sign on. Sometimes it takes a couple minutes to get through that login process, so we're just giving people a couple more minutes. Hi, Dr. Chan. I see you're unmuted now.
Got it. Thanks so much.
Great.
Okay, let me know when I'm ready, when I can
Okay.
go.
Yeah, will do. So I'll just wait one more minute as people, sometimes it takes a couple minutes to log in, and then I'll go ahead and introduce you and the program.
Excellent. So that's one. Just been through. Hey, Joshua.
Okay, let's go ahead and start. So welcome to New Developments in Ovarian Cancer Surgery. I'm Stephanie Blaufarb. I'm the Ovarian Cancer Program Director at SHARE. And before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast and ovarian cancer for the last 42 years. By offering the support of those who've been there, SHARE offers many services, including a helpline, telephone and in-person support groups, and educational programs. And many of these are specifically for those living with ovarian cancer. All services are free of charge. For more information, visit our website, sharecancersupport.org. All participants will be muted during the presentation. When the presenter finishes speaking, we will open up for question and answer. You're welcome to submit questions during the presentation through the question pane on the control panel on your screen. You'll see it should be on the right side of your screen. There's a little place where it says questions. You click on that. You can type your questions all throughout the presentation, and I'll read those out at the end. When asking questions, remember the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. So now to introduce our speaker. Dr. John Chan specializes in the surgical and medical treatment of ovarian and pelvic cancers at the California Pacific Medical Center. He is board certified in gynecologic oncology and obstetrics and gynecology. He is investigating new treatments for gynecologic cancers, including targeted biologic therapies, and exploring the role of tumor-initiated cells in ovarian cancer. He's a clinician and a surgeon. Dr. Chan is a principal investigator of studies assessing the treatment and health outcomes of ovarian and uterine cancer patients. Welcome, Dr. Chan, and take it away and let us know more about gynecologic cancer surgery. Well, it seems like your audio is not connected. So maybe you want to make sure that connection is working. Hold on just a moment, folks. We're going to, I think that Dr. Chan got disconnected. Oh, looks like he's connected again. Great.
Hey, I didn't do anything. My computer, I think you guys logged me off or no? I just don't want this to happen while my talk is going.
Yeah, sorry about that. I'll make sure that you don't get disconnected.
Okay,
All right.
thank you. Perfect. Can I start?
Yes, go for it. Thank you.
All right. And how's my audio? Does everything sound okay?
Yeah, sounds good.
Okay. I want to thank everybody for giving me the opportunity to present to you our advances with respects to ovarian cancer, uterine cancer, and basically gynecologic cancer surgery. Over the next 30 to 40 minutes, I want to be able to cover several topics. I don't have any relevant disclosures associated with surgery of GYN cancers. So a brief outline about what we'll talk about is first, ovarian cancer, how surgery can be used to prevent ovarian cancer, and what are our updates on that. Another is, if a patient is diagnosed with ovarian cancer, what is the role of doing upfront surgery versus doing chemotherapy first, or called neoadjuvant treatment, and how do we select patients for this? Then, what is the role of taking out tumor or cytoreductive surgery and taking lymph nodes? And then also, if your cancer recurs, what's the benefit of doing surgery again on these patients? With respect to uterine cancer, I'll talk to you about some new advances that we have with respect to minimally invasive surgery with fluorescence guidance. Cervical cancers, what are some of the new trials that actually showed some concerning results with respect to minimal invasive surgery and some of the harms that can potentially occur associated with minimal invasive surgery over open surgery. And then also, how do you personalize treatment for this? Any questions? Next slide, we're going to go over some of the big challenges associated with this disease. The number one, I want to put it in perspective for patients with respects to what is the problem of GYN cancer versus other cancers. So clearly, breast cancer is the most prevalent cancer that we deal with, about 250,000 new cases per year. But if you look, right after that is the uterine cancer, ovarian cancer, and cervical disease. And these, the most common is uterine cancer, which is caused by unopposed estrogen and obesity. And the second is ovarian cancer. And we'll talk a little bit about how ovarian cancer, although it's not as common as uterine cancer, only about a third of the uterine cancer, but it is clearly the most challenging to treat. And that's why you see the mortality rate is about 14,000, even though new cases, there's only 20,000. And then cervical cancer, because of some of the prevention opportunities and early treatment, this disease is actually decreasing, fortunately. All right. Next slide, I'm going to talk about some of the reproductive factors for ovarian cancer. So the first topic I'm going to talk about is, how do you get ovarian cancer? Some of the reproductive factors that we've realized is that patients who ovulate a lot over their lifetime, like who? Patients who have early menses. They started their periods early. They stopped menses late. These patients have more ovulatory cycles in their lives. They have an increased risk. Those patients who are protective are those patients who take oral contraceptives because they decrease ovulation every month, and those patients have their ovaries protected. And also patients who have a lot of kids, because when you are pregnant and when you're lactating, you also have a decreased risk of ovarian cancer. Now, in addition to some of these epidemiology or kind of like lifestyle differences, there's also genetic risks of ovarian cancer. And this is made famous by Angelina Jolie, who was diagnosed with a gene defect called BRCA gene. And this gene defect leads to an increased risk of ovarian cancer and breast cancer. How common is it? If you take 10 patients with ovarian cancer, only about 1 or 2 of these patients have a gene-associated type of cancer. And if you have this gene, likely you've got it passed on from your mom or your father. These patients typically have a earlier onset of disease, about 10 years earlier, and their risk and lifetime risk of ovarian cancer is about 40% if you have BRCA1, and their lifetime risk of getting breast cancer is up to as high as 80% by the age of 70, 75. So how do we prevent that? So in patients with BRCA, let's do what's easy, right? Of those 10% or 20% of ovarian cancer patients, we do risk-reducing surgery on these patients. With BRCA1 or 2 mutation, if we do risk-reducing surgery, you can significantly
All right, we seem to still be having some technical difficulty with the audio getting cut off. So we'll give Dr. Chan a second to log back on. Sorry for this. Hold on just a moment. Stand by. Thanks. All right, stand by. He's reconnecting now. Okay, I can hear you, Dr. Chan, now. So sorry, folks, about the technical difficulties there. We dropped so Dr. Chan, we dropped your audio actually a couple slides back when you had started talking about the studies.
Which study?
The slides I saw, there was like examples of studies. But I couldn't hear you, but I saw you had some studies up on the slides. So
Okay.
past this, yes, there.
This one? Okay. Oh, great. Okay. So as we were saying, the patients with BRCA1 and 2 present with ovarian cancer and breast cancer at different ages. In a recent study in 2018, they looked at a large registry of patients with BRCA, and they found that patients with BRCA1 presented with their cancers at about 5 to 10 years early. So the study group recommended to take these ovaries out on patients who are with BRCA1 mutation around 35 to 40 years old, compared to BRCA2. Since they present at a later age, it may be wise to keep their ovaries in for a longer period of time so that they get the benefit of the hormonal effects with their bones, cardiovascular health, and also prevention of menopausal symptoms and vaginal health. With respects to uterine cancer, they actually showed a recent study. Dr. Noah Koff published this about 2-3 years ago, showing that even patients with BRCA, they have a slight increased risk of getting uterine cancer after surgery. And these patients with BRCA mutations should consider also removing their uterus as they are taking their ovaries out for prevention of ovarian cancer, because these patients may have a slight increased risk of getting papillary serous, which is a more aggressive cell type of uterine cancer, if you follow these patients long enough with BRCA1 mutation. All right. Another really interesting finding that occurred in the mid-2000s was the fact that those patients who underwent risk-reducing surgeries, when we took their fallopian tubes out and ovaries out, these professors, pathologists, and we confirmed this at University of California, San Francisco, where when we took their tubes and ovaries out for their prevention of ovarian cancer, we did serial sectioning. As you can see in the middle and bottom of this slide, we took their fallopian tubes and we sausage cut them in little sections. And we actually found that about 10 to 11% of the time, you see a small focus of cancer that starts in the fimbria, or the finger-like projections of the fallopian tube. And with these finger-like projections, they thought, well, wait a minute, maybe these ovarian cancers, especially the serous cell types, they don't start in the ovary. They actually start in the fallopian tube. And if they start in the fallopian tube, is it better to take these patients' fallopian tubes out, even to prevent cancer, and maybe delay taking out the ovaries so that they can get the benefit associated with the hormonal function of the ovaries without damaging their hormone function? So with that started a whole new area of research looking at the origin of ovarian cancer, saying that the cell types of the serous cancers may actually originate in the tube. And this led to a lot of molecular studies, like what we're showing you here. And you can see that maybe the ovarian serous high grade actually occur in the fallopian tube. Maybe the clear cell cancers and the endometrioid ovarian cancers occur in endometriosis. And the mucinous cancers may be coming from the gastrointestinal system, because these ovarian cell types generally are not found in the natural ovary, such as germ cells and sex-core stromal cells. And if they're not coming from the natural ovary cell types, are these metastases, such as serous cancers coming from the fallopian tube? So here's the potential hypothesis. You can see this is like a seed and soil hypothesis, where you actually have the fimbria of the fallopian tube dropping cancer cells onto the surface of the ovary. And with that dropping of cancer cells into the surface of the ovary, this is the risk of getting ovarian cancer. So this started a whole new area of research. And this whole new area of research basically talks about, hey, should we be taking ovaries out on patients? And preventing ovarian cancer, not just in the patients who have BRCA, but also in patients who have non-germline or non-cancer risks. So, for example, in a patient who is coming in for a C-section and they want their tubes ligated, why are you just ligating the tubes? Why don't you just cut the whole tube out? For patients who's going to have a vaginal hysterectomy for prolapse, but they don't want to lose their hormonal function. For a patient who just wants their tubes tied after they're done with kids, instead of tying the tube, why don't you cut the tube out? And this started a whole area of research and also collection of data, looking at the potential benefit of removing the fallopian tubes, even in benign disease in a large population region in Canada, hoping that maybe we can reduce ovarian cancer incidence by 40%. That if you remove the fallopian tubes at the time of a benign hysterectomy, you'll decrease the risk of ovarian cancer by 18%. If you just, instead of ligating the tube, you decrease their the tubes or remove the tubes, then potentially you can decrease ovarian cancer. But how long is this going to take to show? And you're taking tubes and ovaries out on young people that are in their 30s. So when you get ovarian cancer in your 60s and 70s, so maybe another 40 years before we actually see results of a true decreased incidence of ovarian cancer by taking the fallopian tubes out to prevent cancer, given this seed and soil hypothesis, right? All right, so the SGO actually made a clinical practice statement. They said, hey, maybe taking the tubes, or called salpingectomy, is a feasible strategy to decrease the risk of ovarian cancer, and even in patients with BRCA gene. So you've already got a lifetime risk of getting ovarian cancer at 40%. Maybe you can delay risk-reducing ovarian resection, but just take the tubes out early and do a two-step procedure. Take the tubes out first, and then take the ovaries out later in order to maximize the benefit of the ovarian function, decrease the risk of ovarian cancer by taking the tubes out, and then later on in the future, towards menopause, then go back in on a second procedure to take their fallopian tubes out. So this is something that the clinical practice statement actually has suggested, but clearly for patients with BRCA, the definitive surgery is to take both tubes and ovaries. All right, surgeries. Let's talk about, so we talked a little bit about ovarian cancer. Let's review. We talked about ovarian cancer. We talked about how, hey, if you ovulate too much, you get an increased risk of ovarian cancer. The new theory is that maybe the ovarian cancer is actually coming from the fallopian tubes. So maybe just take the fallopian tubes out to decrease ovarian cancer. What if we were unfortunate that we're already diagnosed with ovarian cancer? What is the role of doing surgery first? Why should we even do chemotherapy and do surgery second? And what is the role of doing a secondary cytoreductive surgery. So why should we even take patients back with recurrent disease for surgery, and how do we choose patients and individualize surgery for these patients? So here we go. So let's talk about primary surgery first. And you can see the goals of primary surgery is threefold. One is we want to make a diagnosis, because a lot of these patients come in to see us with an ovarian mass. We don't know if this is cancer or not. So by removing the ovaries, we're able to make an accurate diagnosis for these patients. Second thing is, if you take ovaries out, or if you do a surgery for an upfront surgery, especially on early stage ovarian cancer, you want the GYN oncologist or a surgical oncologist to go in there and remove and also biopsy the associated regions to make sure the cancer didn't spread. Because some early stage ovarian cancer patients don't need chemo. So if you do a good surgery on them and you adequately stage them to show that there's no spread of cancer in the lymph nodes, in the omentum, in the other areas in the upper abdomen, potentially you can avoid chemotherapy for a subset of patients with stage 1 ovarian cancer. Now, the other advantage of taking out a tumor is to do cytoreductive surgery when you have advanced disease. What does that mean? That means that I almost tell my patients that doing surgery on ovarian cancer is almost like cleaning a warehouse. You have to go in there and remove the big boxes first. And that's what surgery does. You go in there, remove the big disease. And then what's left over, all the dust particles that's on the floor, that's when we need chemotherapy to sweep it up and to clean it up. All right, so here's the picture. You see, oh, by the way, I'm sorry if the patients who don't want to see some of these anatomy pictures, these will come up and I'll do the best I can to warn them. So here's a picture of ovarian cancer where there's disease. See the small miliary disease everywhere, the tumor nodules along the intestines. All these patients will undergo a maximum cytoreductive effort to remove as much tumor as possible, and followed by chemotherapy for these patients, which is intravenous or intraperitoneal chemotherapy with Taxol, platinum, or novel biologic agents in adjunct. All right, so let's talk about the rationale. Why should we go in there and do surgery first? What's the potential benefit of spending 3-4 hours to remove ovarian cancer and remove tumor nodules? Here it is. So one, we think that by removing as much tumor as possible, what happens is that it causes significant shift in the cell cycling. So all the cells that are sitting there dormant in G0 phase, when you go in there, you remove as much tumor as possible, those cells get angry and they start getting into the division phase, into the metastasis or metastasis, and also into the G1 phase, and they start dividing. How do the chemos work? They work when the cells are dividing. And so it enhances the effect of the chemotherapy, and also by removing the tumor, potentially you increase the perfusion or the vasculature to these tumors and the small little nodules left over. And you can decrease potentially some of these drug-resistant clones by removing them. So the chemo has less work to do. Does that make sense? And then also potentially it improves and restores the host immune system by decreasing some of these suppressive cytokines. So from an immune perspective, surgery can also be beneficial. And of course, from a perspective of quality of life, these patients come in with ascites, patients come in with bowel obstruction. All these patients, by doing surgery up front, you can get them some immediate symptomatic relief. And you can see this is a retrospective study by Dr. Bristow showing that the more cancer you take on this chart, the x-axis is cytoreduction %, and then the y-axis is better survival. So you can see the more tumor you take out, the potentially better benefit associated with this disease. And here it is, retrospective study, basically looking at the GOG by Dr. Will Winters here, showing that the top curve here is the patients who had the blue. They had much better survival when you have microscopic residual disease. And then the light blue is you leave tumor behind. So you can see almost a doubling of the survival when you can leave very little disease behind or microscopic disease behind. And there's an incremental benefit. The more you take out, the better the Kaplan-Meier curve and the better the survival associated with these patients. Well, this came at a very challenging time because there was this, these were all retrospective chart papers. The Europeans said, look, there may be some benefit in just giving chemotherapy first. When you give chemotherapy first, you get better symptoms because you don't have to do such big of a surgery. When you use the chemotherapy to shrink all that cancer down, then your surgery is easier and less morbid. And if there's less morbid, it's less complications, and the healing's better for these patients. But what about all the benefits that I talked about in taking the tumors out early that I just said it 2 slides ago, and I showed in these retrospective studies? So they said, look, we got to do a randomized trial. We have to flip a coin and have the computer decide who gets surgery first, who gets chemo first, followed by surgery later. Because that is the best study that we can do. It is the best science that we can do. It's always easy to go back and look retrospectively at charts, because those are problematic studies. They are filled with selection bias. You only select the good patients for surgery, so therefore your surgery group looks good. The patients who are too old, too sick, you give them chemo first. Of course, their outcome is not going to look good. So they select out all the good surgery patients, and of course, your retrospective study is going to show. So prove it in a prospective randomized trial. That's exactly what these Europeans did. Dr. Bergot did a prospective randomized trial. He looked at over 700 patients, and the computer would flip the coin, and they said, hey, half these patients get open surgery up front, half these patients get chemo first, followed by interval cytoreductive surgery. The American Society was shocked because this is what we showed. We actually showed that surgery up front did not show a better result. That chemotherapy up front was just as good. The primary disease group, the PDS group here, had 29 months of median survival, which was statistically equivalent to the interval debulking surgery, which is these patients who had chemo up front. The curves completely overlap. Wow, so the Americans, who are the proponents of upfront surgery, even today, started looking at this data set and said, wow, what happened here? What were some of the limitations of this prospective randomized trial? And these are some of the things. Number one is that the low rate of complete cytoreductive surgery. So of the group that got surgery up front in Europe, a lot of those patients didn't get very good upfront surgery. What do I mean? Over 40% of the patients did not get maximum cytoreductive surgery effort. So even if the computer flipped the coin and they said, hey, you should get upfront surgery, the doctors didn't spend enough time. The surgeons didn't spend enough time to take out as much cancer as possible. So you didn't see the effect of upfront surgery because you didn't do good enough cytoreductive surgery. And in fact, there was one poster that they presented that 30% of the time the ovaries were left in. Wait, how good is that surgery for ovarian cancer when after your upfront surgery, supposedly maximum cytoreductive surgery effort, you left the ovaries behind? So these Americans think that, hey, we need to repeat this study in the United States when we can have maximum cytoreductive effort. The other problem with this study is that the overall survival of these patients, if you look back at this trial, they didn't do very well. These patients that overall, even in both groups, the survival was suboptimal compared to what we have today. So look at this. In 10 years, your survival at 5 years is probably 10, 15%. So in the United States now, we're probably up to 40%. So the people who are against this trial, these are the things that they said. Lastly, is the patients weren't, the chemotherapy after surgery was not standardized. So yes, you dictated the surgery, but if you didn't dictate the right chemotherapy, and in the two groups, they had different chemotherapies, then maybe that could have affected the results too, right? So those are the challenges associated with neoadjuvant chemotherapy. Here's another study that we looked at survival analysis of randomized upfront surgery versus neoadjuvant. And this is done by the Italians, right? And they basically show that these smaller number of studies, right, of the 171 women, they showed also a no significant difference between progression-free survival and those who had chemo first or upfront surgery first. Where is it today? Where are we today in the United States with respect to upfront surgery versus neoadjuvant? I think most of us in the U.S. still believe that there's some benefit in upfront surgery, although many of us are leaning more and more towards neoadjuvant chemotherapy, especially in patients who are poor candidates for aggressive surgery, especially in patients who had such extensive disease, such as stage 4 disease, with a lot of bowel involvement, liver involvement, and also involvement in distant organs such as pleural effusions or lung disease. Those patients we typically offer neoadjuvant chemotherapy, at least in my practice. All right, so we talk about surgery and some of the controversies with upfront surgery versus upfront chemotherapy, and how we generally save neoadjuvant chemotherapy for patients who have stage 4 or extensive disease to decrease the upfront surgery morbidity. But there was also benefit of potentially changing the chemotherapy. So in this trial that we were involved in and we published in the New England Journal of Medicine, we looked at weekly therapy versus every 3 weeks Taxol. So taxane is a compound that is a kind of started from the Western yew tree bark. And this taxane drug, when you give it in weekly doses, like small increment doses, we showed that there's actually an increase in benefit. And here's the lower portion here, the weekly chemotherapy versus every 3 weeks. Instead of giving big boluses of the Taxol, but give it in 3 small increments, you can actually get more drug into these patients, and potentially this can improve the outcomes of these patients because it can bring better blood supply and chemotherapy to the patients. All right, so we talked a little bit about surgery and then the weekly chemotherapy. Let's talk a little bit about next is second look surgery and also taking lymph nodes out on these patients. So this is a recent trial called the LION trial, which is lymphadenectomy in ovarian cancer, LION, in ovarian neoplasms. And Dr. Phil Harder actually published this paper in New England showing that if you randomize these patients for upfront surgery, either doing lymph node dissection versus no lymph node dissection, there was no benefit. So in ovarian cancer advanced stage, just taking out benign lymph nodes, there's no benefit. In fact, you probably just increase morbidity. So many of us have stayed away from taking lymph nodes out on patients unless they have bulky disease in the lymph nodes. We don't try to do complete resection of the lymph nodes based on this prospective randomized trial. In recurrent disease, and this is a GOG 213 trial that we were involved in, we actually looked at these, giving these patients not just surgery after recurrence, but also different types of chemotherapy. And this is the trial. And we show that there was no significant benefit for doing a surgery up front, or no survival benefit associated with interval cytoreductive surgery. So if your cancer comes back, the GOG 213 study showed that interval cytoreductive surgery to remove more cancer after the cancer recurs, there was no overall or progression-free survival benefit. So recurrent surgery, recurrent ovarian cancer resection, there was no significant benefit based on this prospective randomized trial. And another study from the AGO, which is the Desktop 3 study, we also looked at patients who had platinum-free interval about 6 to 12 months. So they had platinum sensitivity. They were randomized to cytoreductive surgery versus no surgery. But this study showed that there is a slight benefit. So if you select your patients well for recurrent cancer surgery, there was a benefit about 5 months associated with this, these patients. The patients who had interval cytoreductive surgery, which is shown in red here, did better than the patients who had no surgery for their recurrent disease. So the American study didn't really select patients. The German study, they used a selection score to select these patients out for interval cytoreductive surgery. They were able to show benefit. So this is the controversy that occurs today in secondary cytoreductive surgery. All right, what do we do in our practice in cytoreductive surgery? Generally, I teach our students here, and our practice here is that the patients who have isolated disease, patients who had a pretty long remission from their last cycle of chemotherapy, patients who don't have significant comorbidities, can tolerate a surgery, and also the tumor is resectable. If they meet those 4 criteria, I generally offer patients secondary cytoreductive surgery. Okay, that covers ovarian cancer. So let's review here. We covered ovarian cancer, origins of ovarian cancer, how we get it, how ovarian cancer occurs 10-15% of the time in gene-related BRCA. The other 80% of the time, we think that is the epidemiology of over-ovulating your ovaries. So protect your ovaries by taking birth control pills. Those patients who have BRCA, take your tubes and ovaries out. Those patients don't have it, potentially we can prevent it by just taking the tubes out. When you are diagnosed with ovarian cancer, surgery helps with diagnosis, helps to make sure you don't have spread of disease if you have early stage cancer, so potentially you can avoid chemotherapy. In patients who have advanced disease, who have good resectable disease, try to take out as much cancer as possible. Those patients who are medically morbid and who have stage 4 disease, maybe offer them chemotherapy first, followed by surgery later. And if you select your patients out well with recurrent cancer, there may be a potential benefit in resecting the tumor and retreating them with chemotherapy again. All right, so that covers ovarian cancer. And in the next 15 minutes, I'm going to cover uterine cancer surgery. And this is the new robotic system that we have now. We're into our 3rd or 4th generation of robot. It gives us, from a surgery perspective, high resolution 3D visualization, fully articulating endo-risk instruments, intuitive movement and motion scaling, and it decreases the tremor. So because of this $3 million robot, potentially we can do more precise surgeries. I'm going to show you a video of this surgery, and you can see, based on this video, the top is the robotic arms, the bottom is our hands in doing the surgery, and you can see how intuitive the motion of these surgeries are compared to, let's say, straight stick laparoscopic surgery. And therefore, by doing the robotic surgery, you can not only decrease tremor because you can scale the robot, but you can also have much better precision. And when the physician or the surgeon is actually sitting down and operating, potentially you have less fatigue, and the surgery is safer and more comfortable for the surgeon. And this increases the efficiency of the surgery and potentially decreases risk of complications associated with this procedure. And in fact, you can see this picture here, even our ex-president, Obama, was trying out the Da Vinci system at Cleveland Clinic in the late 2000s, testing out the Da Vinci procedure. U.S. News and World Report in 2010. You can see the front cover, America's Best Hospitals, and they have a robot here in the front cover showing that, essentially suggesting that the best hospitals have robotic systems that help them with their procedures. But nonetheless, there are some disadvantages. These robots take up more time, they're bulky, for thin patients, a narrow pelvis, they're actually more difficult to use. There's no tactile feedback, so I don't have resistance when I'm operating. The robot doesn't give me feedback on how hard I'm pushing the needle or how hard I'm driving the needle. And then also, there's a lot of market pressure for us to use some of these robots in our surgery, and the patients also want some of these procedures done. And I'm going to talk about how these market pressures can lead to some challenges later in cervical cancer. And you can see here, using the robotic system, you can actually use it to map the lymph nodes that are potentially involved. So these fluorescent dye using blue dyes or other radio-labeled technetium and also ICG dye here on the right, you can see you can isolate these lymph nodes a lot easier. And I'll show you a video of this right now. So you can see we're using the robotic Da Vinci, and we're trying to dissect the lymph node out here. We're isolating the lymph node out, but once you step on a petal and you can see the green fluorescent dye, you can easily detect areas where the lymph nodes potentially could be involved, and we can isolate these lymph nodes and resect these lymph nodes out. And you can see under the white light here, it's not as apparent where the potentially involved lymph nodes are. But once you put the green light on, as we'll show you in a second here, you can see how by resecting this using the green light, it completely isolates the area where there may be higher cell division or potentially where the metastatic cancer is. And also you can potentially use this green light to differentiate between normal structure, where everything looks yellow here in terms of a lot of structures. The green light can significantly enhance the area of concern in surgery and also prevent you from injuring the normal structures in the anatomy. And that adds significantly more to our surgery in terms of not just be able to have more precision, but also decrease risk of complication. And here is us resecting the lymph node out, and we'll show it to you, the lymph node out in green here. Okay. All right, last 5 minutes. I want to talk about cervical cancer, okay? And this cervical cancer really hit the news. If you look at Wall Street Journal, look at the Times, and look at CNN, you'll see that cervical cancer surgery came into a lot of controversy over the last year. Here it is. So you see on the top, this is a New England Journal of Medicine trial that we ran called the LAC trial. And on the bottom, here's CNN saying, in cervical cancer surgery, minimally invasive surgery, which is the awesome surgery that I just showed you over the last 5 minutes, is worse than open surgery. So our phones went off the hook in terms of our research group and also our practice, talking about how potentially minimally invasive surgery is worse than open and why. So this is what they showed. At an open surgery, which is on top here, the Kaplan-Meier curve, you had 90+% overall survival. And when you actually use minimally invasive surgery, you decrease the survival associated with these patients. So what happened? So when you looked at the LAC trial, they talked about how radiation therapy needs to be personalized, and that we need to really discuss the theoretical mechanism associated with why this could have happened. And we also need to look at maybe developing a better algorithm to personalize cervical cancer surgery, instead of to every patient, but maybe select out which patients will benefit and which patients can potentially be harmed from laparoscopic or robotic minimally invasive surgery. Harms, why? What can explain this? So this is some of the slides that I came up with, and I talked to my patients about this. Why potentially the pneumoperitoneum, which is the gas that we put into patients when we do laparoscopic and robotic surgery, maybe that it increases phagocytic activity in the peritoneal macrophages, and the capacity for the macrophages to work is hindered. It decreases intraperitoneal pH from all the gas that we put in, and also the tumor necrosis factor alpha production is decreased and suppressed. And that may potentially lead to more recurrences and more port site metastasis associated with our surgeries. So maybe it's the pneumoperitoneum that harmed the patients. And because you don't get that with open surgery, okay, that resulted in the worst survival associated with minimal invasive surgery. Also, the other problem is potentially the patients who got enrolled in these trials, the surgeons didn't have the good experience. So when we did a retrospective analysis of the NCDB database, we looked at 319 patients. You can see here, the patients who actually got operated on in 2012 did a lot better than 2011 and 2010. Wait, does that mean that these surgeons were still on their learning curves and that the more experienced surgeon would lead to better results? It's possible, right? But clearly, we need to do another prospective randomized trial with only very well-experienced surgeons after 2012 before we can really say this, right? Because this is retrospective data from the National Cancer Institute. So in our clinical program, what we potentially offer patients is you have very small disease, stage 1A, millimeters of disease, less than 2 centimeters. Maybe minimally invasive surgery is still potentially an option because it decreases the risk and morbidity. And in a retrospective study, we showed that the harm that happened with minimally invasive surgery mostly happened in patients who had 2 centimeter or greater disease. So for bulkier tumors, do open surgery. For smaller tumors, less than 2 centimeter, maybe minimally invasive surgery is still adequate. All right. All right, that's it. So we're going to talk about some future direction. One last slide. We're going to talk about future directions. This is a new robot that we're working with to develop new techniques, maybe doing a single site, single port. So your camera comes out and your incision arms comes out on the side here using 3 different arms. And this allows for better cosmesis because it's a single port instead of having 3 or 4 ports that are 8 millimeters. And that single port will allow us to use these visualization and also the benefit of robotic surgery much better than a big vertical incision or 3 or 4 holes. This is the future directions. Maybe using Google Glasses in the future, wearable technology that can display 2 different screens. So you have surgical mentors for patients who are, for doctors who are not as experienced, so we can enhance better training for surgery in the future, even remotely. Using the Google Glasses and the new technology can probably increase 3D visualization so that you can incorporate the CT scan, MRI, PET scan while you're doing robotic surgery to look at it in a 3-dimensional fashion. You can even put these in a 3D Google Glasses in the future, so you don't need to wear them. You can put these on as a lens in the future. And here is a technology that they're actually using in certain medical school now to teach doctors to use these wearable technologies, and how can these wearable technologies in the future be used in the operating room to do surgery when you enhance the visualization of these procedures and use the 3D imaging and literally unveil the patient's anatomy during the procedures so that you can enhance the surgical precision in the future, even beyond what we can do from a more 2D format, but instead using a 3D format to enhance the safety of these procedures. All right, last slide, we're going to outline it, and we're done. So ovarian cancer, how can we individualize prevention surgery for BRCA patients, individualized surgery for even patients in the general public, how upfront surgery versus neoadjuvant surgery may need more confirming in our United States trials, but many of us are moving more towards neoadjuvant chemotherapy in the United States. Complete surgery with taking out lymph nodes that are benign, no benefit. Secondary cytoreductive surgery, unless you select these patients well, there may not be a significant benefit. So we've got to really learn how to personalize the surgery for these patients in order to optimize the benefit with your surgeon. Uterine cancer, minimally invasive surgery with fluorescence, clearly an excellent option, and probably going to help a lot of surgeons to detect metastasis. To cervical cancer, the minimally invasive surgery is significantly decreasing, and in that trial, it's clearly practice changing. And we also discussed some of the personalized surgery in terms of future directions to enhance operations for our GYN cancer patients, and so in hopes of not only to decrease complications, improve survival, but also significantly enhance their quality of life without significant recovery for these patients. Thank you so much for having me.
Great. Actually, so I had a couple questions that came in, if you have a moment. And I also wanted to mention that if folks are able to have questions, they can still submit them, and I'll read them out. But we just had a couple that were submitted. So one woman was asking if it would be beneficial for a woman whose mother had ovarian cancer, however, her mother did not have the BRCA mutation, should the daughter think about having her fallopian tubes removed, and if so, at what age?
So let me answer that in a two-part answer. One is just because your mother had ovarian cancer and she's BRCA negative, those patients may have a slight overall increased risk of ovarian cancer, but not as if the patient had the BRCA mutation with a 40% lifetime risk of getting ovarian cancer. So for a patient whose mom does not have the gene and taking out the ovaries at an early age, we don't recommend that. Now, your second part question is interesting, which is, hey, should you take your fallopian tubes out? I think that is a personal choice that you should discuss with your surgeon with respects to what's good and what's bad about doing that, okay? I don't know of any studies by taking the tubes out on a patient whose mother had ovarian cancer, you're going to significantly decrease your risk of ovarian cancer. But I think some of the studies show that, and these are all, of course, kind of like modeling studies, right? Looking at potentially how many % of ovarian cancer is actually caused by fallopian tube, and by removing fallopian tubes out in the general population, potentially there's a benefit, probably 18% or maybe a 30% decrease in reduction. But we still need the data to prove that. Number one, we don't have outcomes. We don't have a decreased incidence. This is all modeling. Number two, problem with taking the fallopian tubes out is maybe an unnecessary surgery. So if you're not going in for a surgery by taking the fallopian tubes out, are you causing harm? Two other considerations before the patient decides to do that is, number one is when you take the fallopian tubes out, are you decreasing ovarian function? And also, by taking the fallopian tubes out, have we looked at long-term on these patients with respects to potentially early menopause or potentially harm associated with this? I think that needs further study. But nonetheless, there are regions in Canada and many the doctors who are benign GYN doctors in San Francisco are already taking their tubes out while they're undergoing a tubal ligation thought procedure or a C-section.
Okay. So another question is, somebody asked, is it true that using the robotic option or minimally invasive surgery for ovarian cancer surgery has some negative feedback? Or that's the question, but what do you think about robotic surgery for ovarian cancer?
Yeah, so so the robotic surgery and the minimal invasive surgery that showed harm were in the cervical cancer patients. In ovarian cancer, there has been retrospective studies showing that laparoscopic is feasible, it's safe, but we don't have long-term outcomes and prospective trials showing harm or benefit. But clearly, a patient who has an isolated disease and a robotic or laparoscopic surgery can be performed, I think that is a reasonable choice. In uterine cancer, we did do a prospective randomized trial comparing laparoscopic surgery to open surgery, and we did not show a harm in uterine cancer. So let me summarize. Ovarian cancer, retrospective studies shows no harm in laparoscope versus robotic. In uterine cancer, prospective randomized trial shows that minimally invasive surgery is as good as open surgery and safer and easier to recover. In cervical cancer, we showed that minimally invasive surgery is associated with more risks and more harm.
Okay. Well, we run out of time, and thank you so much for your time and sharing all this information with us. This program has been recorded and will be up on our website soon. Also, if you could all please take a moment and fill out the survey that will pop up at the end of the webinar. That'll just take a minute to pop up after the webinar ends. Well, so thank you all for joining, and thank you again, Dr. Chan.
Hey, thank you so much for having me.